He is a very senior ENT surgeon, and he is a faculty in SM Silchar Medical College Hospital, and he's also a senior consultant in Green Hill Hospital, Silchar. Dr. Kripamoy Nath passed out his ENT postgraduate from Assam University, Silchar in 2004, and post that he has rich years of experience, more than 15 years of experience. Presently, he's a faculty, as I told you, at SMCH Silchar, and in past he was also associated with GMCH Jorhat, SMCH Silchar, and AMCH Dibrugarh. Uh, Dr. Kripamoy Nath is a member of Association of Otolaryngologists of India, Foundation for Head and Neck Oncology, Indian Society of Otology, Northeastern Branch of Otolaryngologists of India, Northeast India Working Group of Endoscopic Ear Surgeon, and he's also a member of Indian Medical Association. He is a frequent external examiner for MBBS professional examination for ENT subject. He has numerous publications to his credit, and he is involved in numerous research activity. Dr. Kripamoy Nath has also organized NEBACOIN 2019, and in past he has presented numerous work in NEBACOIN conferences, which was held in Silchar and Arunachal Pradesh. He is also very fond of photography, and he also holds a distinction in professional diploma in photography from Shaw's Academy in 2020. On behalf of all the participants and all the attendees today evening, I welcome you, sir.
Thank you very much. Can I share my screen?
Yes, sir. Yes, sir. Uh, just if during the course of any of the lecture, in case of any questions and doubt, you can post your questions in Q&A section, which features at the bottom of the screen. Welcome, sir.
Am I audible?
Yes, sir.
My
Perfect.
slides visible?
Yes, sir.
Okay. Thank you very much for that kind introduction. At the outset, I would like to thank the team Walter Bushnell for inviting me to discuss on this topic, that is your understanding allergic rhinitis in a better way. Though this topic is very less discussed in general people and in general practice, but we as a ENT specialist should talk more and more on this subject, as if we can stop the allergy at right place, then we can stop the further proceedings. That is, if you can stop the sneeze, then you can stop the wheeze. Now, allergic rhinitis has many multimorbidities. You can find it from like atopic dermatitis to asthma, and then there are some clinical manifestations like your conjunctivitis, rhinosinusitis. On examination of the nose, you will find the turbinates are very much hypertrophied. In children, you will find adenoid hypertrophy. Then in the ear, you will find fluid in the middle ear, which will lead to hearing impairment in children. And there will be learning problems in children. Along with that, there will be laryngitis, then laryngopharyngeal esophagitis, and esophageal reflux disorders. All those things will come. Most important thing is that you have to stop the allergic rhinitis at the onset. Now, coming to the epidemiology, you have to, when you go to the epidemiology, you'll see that on the literatures, there are the incidence of this literature, this allergic rhinitis is very vast. from 10 to 40%. The range is very big. Why? Because of the geographical differences. The definition of allergic rhinitis is also differ from place to place and seasonal variations. It is highest seen in children and it is absent, you can say absent in infant. Now this is the world picture where you will see that it has a highest incidence in all the developed nation like USA, Latin America, Europe. Then you have China, Taiwan, Middle East. All those areas have incidences are very high. The reason behind that is because of the hygiene hypothesis, which was postulated. But how far it is correct, it is unknown. Now, this is Indian scenario where you will find that uh, 20 to 30% of Indian populations suffer from allergic rhinitis, and out of that, 15 to 20% develop asthma. So it is related. Allergic rhinitis and asthma is related to some extent. It is your 15 to 20%. Now, this is a study conducted by Keshinath Bhattacharya and others, which shows that approximately 25% of the total population of India is sensitized to different forms of allergens. That means if you that means a lot of populations are sensitized to certain group of allergens that may manifest their symptoms uh, later on, or it will manifest at some point of time. Now, the allergens may be your pollen, grains, fungal spores, foods, insects, and dust mites. These are the common allergens found in our country. Regarding the pattern of distribution, you can see that the it is mostly seen in your southern part of the coastal part of the India, along with Kerala and some part of the Mizoram and Arunachal Pradesh. So these have the higher incidence of your uh, allergic rhinitis. Now coming to the manifestations, like your allergic rhinitis have the mouth breathing, chronic mouth breathing because of the hypertrophy of the adenoid. The hypertrophy of the adenoids causes obstruction of the normal airway in the children and leading to high arch palate and the malocclusion of the teeth, leading to this type of dull looking face, and there will be conjunctival and ocular symptoms. The patient may have the constant rubbing of the nose, leading to uh, there will be crease formation of the horizontal crease of the dorsum of the nose, that is called allergic salute. There will be lines below the lower eyelid, that is called Denny Morgan lines. And on examination, you'll find that on anterior rhinoscopy, you'll find the inferior terminates are hypertrophied and bluish in color, pale in color. On pharynx, you'll find that there will be granular appearance of the posterior pharyngeal valve and with conditions. As I said, allergic rhinitis doesn't stop there in the nose. The manifestation you find there in the ear also. There will be fluid behind the intact drum, which can be seen on otoscopy through the tympanic membrane. If the tympanic membrane is very thin, then you can see the fluids behind the middle ear, fluids in the middle ear with air bubbles, and sometimes it is retracted also. So these are the various types of presentation in the in a person suffering from allergic rhinitis. Now here I like to mention about the allergic march. This is like the allergic rhinitis patient can suffer from the initially with the skin irritations, or that is called atopic dermatitis. And as the child grows, he develops allergy to food like peanuts, cow milk, egg, wheat, soya, fish, etc. And later on, he develops the seasonal allergic rhinitis to pollens, etc., environmental, external environmental. And if it is not treated here, then the patient can go to the next phase, that is your asthma. That is a chronic disease, and because of the inflammation of the airway, the patient suffers a lot. So, this is the progress of the disease from the child to the adult. Now, coming to the classification, you have the world accepted classification, that is ARIA classification. Here, the allergic rhinitis is classified into intermittent and persistent. In intermittent group, you have the uh, disease less than 4 days per week, or uh, or for 4 weeks, less than 4 weeks. And in persistent group, you have the more than 4 days per day week or more than 4 weeks. So you classify like this. And regarding the in severity, you can classify into mild or into moderate to severe classification. Now, in moderate to severe, one or more of the symptoms will be there, like your one or more of the symptoms will be there, like your abnormal sleep. You have the impairment of the daily activities, or there may be absence of the work or school, or there may be some troublesome symptoms. If these symptoms are not present, then you classify it into mild variety. Now, why it is important this classification? Because depending on this classification of the ARIA, they suggested the treatment options. What are the treatment options available? Yeah, in the mild intermittent, uh, moderate, you have the mild intermittent, moderate to severe intermittent. You have the mild, moderate, persistent, and severely persistent. In all of these cases, we have to go for allergens and irritant avoidance. This is the main thing. And in mild intermittent, you can use intranasal cromolins, and that is your mast cell stabilizers. Uh, uh, and in moderate to severe to severely persistent, you can use intranasal corticosteroids. In very severe cases, you can use very short course of oral corticosteroids for 3 to 7 days. And these H1 non-sedative histamines can be given in all of the cases. Then intranasal decongestant should be given less than 3 days. And the topical symptoms, if it is there, you can give antihistamines. Local antihistamines can be given for your local oral in this ocular causes. And if after the symptoms are not controlled, then you can advise the patient for immunotherapy. That is a separate thing. Now, ARIA guideline, uh, when you choose the treatment, you have to monitor the patient. Monitoring of the patient is very important, because you cannot give the patient the treatment for a longer period of time, because there are some side effects of these medicines. So you start with the first line medications, and you have to switch to the second line medications. When you want to switch, you have to do the visual analog scores of the patient. You have certain questionnaires are there, and those things are given to the patient. They will fill up, and scores are measured. The visual analog score, if it is less than 5, you continue with the first line the medications like your H1 histamines, intranasal corticosteroids or glucotrienes receptor antagonist, or is intranasal corticosteroids plus zilastin, depending on the severity. If the visual analog score is more than 5, then you have to add these like your any suitable therapy, or your you have to depend on the intranasal corticosteroids and azilastin. Then you don't have to give this one antihistamines, and you have to reassess the patient's visual analog score uh, at 2 to 3 days. After 2 to 3 days, if the visual analog score improves, then you step down the therapy. If it doesn't improve, then you continue the treatment and again reassess after 2 to 3 days. Now this was all about the flow chart. And what about the European guideline is to say, again the same thing. If there is two or more symptoms are there, you have to start with the nasal corticosteroids, antihistamines, and then if it is visual analog score, it is more than 5, you have to shift to the higher, that is intranasal corticosteroids, then antihistamines, nasal antihistamines, nasal corticosteroid spray, then combination of nasal corticosteroids plus oral antihistamines. Similarly, if it is not controlled or uncontrolled and visual analog score is more, then you subject the patient for your immunotherapy along with this treatment. Now, American Association of Family Physicians has given some guidelines on allergic rhinitis. They said this diagnosis of rhinitis should be made with the history and physical examination findings, and the serum specific IgE, that is blood or the skin, should be performed with the patient and should be assessed for the presence of associated conditions such as asthma. You have to ask the patient regarding the uh, asthma, because the patient will not tell that I am suffering from the asthma. You have to put your stethoscope on the chest and you have to examine patient's lung condition. And imaging has no role, not so much role in the diagnosis of allergic rhinitis. Intranasal steroids should be prescribed for patients with allergic rhinitis. They also mentioned it. And intranasal antihistamines may be prescribed. They also mentioned the same thing. Oral second generation antihistamines of less sedating properties should be prescribed to the patients with allergic rhinitis. Now, coming to the oral leukotriene receptors antagonist should not be prescribed as first therapy for patient with allergic rhinitis. So here it is very important to note that oral leukotrienes are not to be prescribed. Now, combination pharmacologic therapy may be prescribed for patient with allergic rhinitis. It is safe, and avoidance of allergen or environmental control may be considered for patients with allergic rhinitis. Immunotherapy should be prescribed for patients with allergic rhinitis. Regarding surgery of the inferior turbinate reduction, may be considered if there is severe blockage of the nasal cavity to improve the uh, delivery of the intranasal corticosteroids or antihistamines. Now, coming to the pharmacological options, you see that the you have the oral histamines, you have nasal antihistamines, then intranasal corticosteroids, leukotriene modifiers, anti-leukotrienes, then oral decongestant, nasal decongestant, mast cell stabilizers. You'll see that most of the symptoms like sneezing, itching, congestion, rhinorrhea, eye symptoms are covered with your intranasal corticosteroids. So it has a very important mechanism of action and controlling of the total nasal symptoms, whereas leukotriene modifier has very less efficacy in sneezing, itching, congestion, rhinorrhea, and other things. So similarly, others are not up to the mark of your intranasal corticosteroids. Now here ICAR has proposed uh, some guidelines, some recommendations, some options after doing a very large meta-analysis. Now let me tell you what is ICAR. ICAR is International Consensus Statement of Allergy and Rhinology. They published this guideline in the month of February 2018 after doing a PubMed database research from 1947 45 till date, and they accumulated the data, huge data, and were comprising of your large meta-analysis, randomized control trial, and clinical trials. They divided the topics into 103 topics, and those are very much important for the allergic rhinitis and its treatment, and summarize the findings according to the meta-analysis and other systemic review identified on the literature of the specific allergic rhinitis. And certain topic areas have very strong evidences, whereas other topic demonstrated very weak evidences. Their recommendations in these documents are evidence based, and ICAR analyzes the existing literature on the each allergic rhinitis topic and grading them further with the evidence and providing literature based recommendations where appropriate. So we'll see that the recommendations along with the topics. How they recommended, they grade them into A, B, C, D according to the evidence. And the if it is a well designed randomized control trial, and they recommended as strongly recommended, or if it is observational like it is, they have recommended recommendation only, or some expert opinions are there or case report, they have recommended into option. So they you will be finding like this. Now coming to the definition, as you all know, the allergic rhinitis is a IgE-mediated inflammatory nasal condition resulting from allergen introduction in a sensitized individual. And we have to differentiate this allergic rhinitis from the other causes like your drug-induced rhinitis, then rhinitis medicamentosa, occupational rhinitis, or whole lot of other conditions are there which can mimic your allergic rhinitis, but the physiology and the treatment is all to be different. Now, these are the phenotypes, like a non-allergic rhinitis or senile rhinitis, which occurs in more than 65 years of age, which is mucosal or glandular atrophy. Okay, and the treatment will be your epidromium bromide in this case. Gustatory rhinitis, some patients may have gustatory rhinitis after eating the hot and spicy food, they develop rhinorrhea. That is because of the neurogenic inflammation. And it is to be avoided. Avoidance is the main treatment with nasal capsuline. Occupational rhinitis is also there, where some patients complain that on weekdays I develop rhinitis and on the weekend, like on Saturday and Sunday, I feel better. Those are the patients, they are allergic to their occupational environment, and that is because of the neurogenic inflammation. And the treatment will be your avoidance or change in the uh, change in the occupation or change in the site of occupation. Hormonal rhinitis like your pregnancy induced rhinitis, then idiopathic rhinitis is also there. So these are all phenotypes. Along with that, the different treatment options are there. The pathologies is also different. There is quite overlap of phenotype between the allergic rhinitis and the other. Here, I like to mention the allergic rhinitis is the IG mediated inflammation where there is inflammation, and the local allergic rhinitis is also there in uh, the subset. And regarding the non-allergic rhinitis, rhinitis of the elderly, then occupation elderly, and some part of the drug-induced rhinitis are unknown etiology. Gustatory rhinitis, idiopathic rhinitis, irritant rhinitis, these are neurogenic. Infectious are your acute rhinosinusitis, and the atrophic rhinitis and the chronic rhinosinusitis is because of the structural abnormality. So there is quite overlap between the signs and symptoms. So you have to differentiate all those different types of rhinitis before proceeding the treatment. Now, let a few words about the local allergic rhinitis. It is also called entopy. One third of the rhinitis patients are classified into local allergic rhinitis group. Localized nasal allergic response in patient with negative skin prick test. Here you have to note down that there is negative skin prick test and absence of detectable specific IgE2 inhalant allergen in the blood. So, local production of serum specific IgE and type 2 T cell cytokine patterns of mucosal cell infiltration, positive nasal allergen provocation tests are the main uh, criteria to diagnose those patients. Allergen specific basophil activation in the peripheral blood is also seen. The diagnosis of local allergic rhinitis can be confirmed by the detection of the nasal serum specific IgE or a positive uh, nasal provocation test or both. Now, coming to the pathophysiology of allergic rhinitis, this is very important actually, because if you can understand the pathophysiology of the allergic rhinitis, this becomes very much easy to treat the patient. At what level you want to give which type of medications, which medications will work at what level. If you know that part, then it's become very much easy. Now here is a chart where you see that that this is the nasal epithelium. It has some uh, sinonasal immunity. Sinonasal immunity means it has its own defense mechanism by your uh, nasal secretions, by its cilia movement towards beating towards the nasopharynx, clearing the antigens from the nasal cavity. If this sinonasal immunity is lost or it is breached, then the antigens enter into the nasal cavity and it is taken up with by the dendritic cell, and it is presented to the T lymphocytes. Now these T lymphocytes will this antigen presenting cell, this dendritic cell, when it takes up the antigen and presents to the T lymphocytes, it is called antigen presenting cell. It has MHC class 2 molecules which attaches with the antigen to the T receptor cell and CD4. This uh, combines with to the your T2 helper lymphocytes. Now, this will secrete interleukin 4 and 13 to stimulate the B lymphocyte, and this will generate your maturation of the B lymphocyte to the plasma cell. That is called class switching of the uh, B lymphocyte into plasma cell, and IgE is produced from the B lymphocyte in place of IgG. Now, normally, normally the this IgG is produced, but as it is uh, there is clonal expansion and class switching of the plasma cell, it produces IgE. Now this IgE will antibody will bound to the mast cell. Now once it is bound to the mast cell, the mast cell becomes sensitized. Now the patient is called sensitized. And on repeated exposure on subsequent exposure to the same allergen, these antigen antibody complex will form, and this antigen will bound to the antibody, and this complex will degranulate this mast cell, and there will be release of this histamines, pituitary, prostaglandins, tryptase. Okay, now this histamine causes vasodilatation, exudation, and there will be rhinorrhea, and because of edema, there will be irritations of the peripheral nerve, and there will be itching. This is your early phase. Now, what happens in the late phase? There will be lot of cytokines are involved. These interleukins, then eutexin, rantase, then ICAM. These are all involved to recruit this eosinophil and basophil into the site. Into the site means in the nasal cavity, submucosa. So these recruitment causes more and more eosinophils are involved from the this maturation of this eosinophil and basophils occurs from this bone marrow, and they are recruited into the submucosa. So more and more cellular infiltrates will be there, and there will be more and more nasal conditions will be there because of this cellular infiltration. So this is in nutshell about the uh, pathophysiology of the allergic rhinitis. Now, what are the proposed risk factors for development of allergic rhinitis? As per this is all about the ICAR guideline. They say the genetics has a some genes have been associated with development of allergic rhinitis and other atopic diseases. So they have graded them into grade C, and restriction of the diet in utero or in the pregnancy, they have this maternal diet restriction while child is in utero is not a contributing factor, so they have strongly recommended against it. Tobacco smoke, similarly, most studies found no association between the active and passive tobacco smoking and allergic rhinitis. Then socioeconomic status. Most studies shows an association between high socioeconomic status and allergic rhinitis, but this is not a consistent finding across all studies. So the hygiene hypothesis is again null and void in this case. Now, what are the protective factors against the development of allergic rhinitis? You have the breastfeeding, pet exposure, then you have the hygiene hypothesis. Regarding breastfeeding, option for breastfeeding for specific purpose of allergic rhinitis prevention. In general, breastfeeding has been strongly recommended due to its multiple beneficial. So it is an option rather than a recommendation. Regarding pet exposure, there is no recommendations. Regarding microbial, this hygiene hypothesis, it is also not recommended. Now, effect of allergic rhinitis on individuals' quality of life and sleep, both are affected, and it is recommended that allergic rhinitis affects quality of life and sleep. So we have to consider these two things in the history. Now, technique for evaluation and diagnosis of allergic rhinitis. Regarding the clinical examination, that is your history and physical examination, it is recommendation is there. Everyone should take a proper history. At least you have to spend 15 to 20 minutes to take a proper history regarding the onset, duration, then family history. other environmental factors and other things, you have to take the upper history. Now, coming to the nasal endoscopy, this is an option. Evidence does not support the routine use of nasal endoscopy for diagnosis of allergic rhinitis. However, it may be helpful in ruling out other causes of symptoms like your turbinate hypertrophy or nasal polyps or your mucosal edema there in the middle meatus or any other pathology. Radiological imaging is again it is not recommended. Use of validated survey instruments like your visual analog score, as I mentioned earlier, it is strongly recommendation is there. So you have everybody should use this uh, visual analog score. Then skin prick test regarding this, there is recommendation is there. It is recommended for evaluation of allergic sensitivities in appropriately selected patient. It should be done. The practitioner may decide whether skin or the in vitro, that is your blood testing, is best in an individual patient. So the physician will decide which one has to be done. Skin interdermal testing. Uh, this interdermal testing may be used in determine to determine the specific airborne allergen sensitization for individuals suspected of having allergic rhinitis. So this is the option. Now coming to the serum specific IgE, it is recommended. It can be done for evaluation of allergen sensitivity in appropriately selected patients. The practitioner may decide whether skin or in vitro skin serum specific IgE testing is to be done. Now, correlation between skin and vitro testing. Here, nasal serum specific IgE, this is option. Basophil activation test, this is a research based product. Very cost. It is not done routinely. Nasal propagation test is also not done. It has to be employed for diagnosis of occupational rhinitis or local allergic rhinitis. Then nasal cytology is rather than it is not investigational to rather a diagnostic. That nasal histology is used for research based. So these are all option. You can use it, but it is not recommended. Most of them are research based investigations. Now, your treatment of allergic rhinitis has three pillars. The most important is your allergen avoidance. That is not possible in all cases. So we have to depend on these two. That is your pharmacotherapy and immunotherapy. Let's come to the pharmacotherapy. How where it works. Your antihistamines. First is your allergen avoidance. If you can avoid the allergens at the level of your nasal epithelium, then you can prevent the uh, further disease progression of this cycle. And next is your cytokines inhibitors. These cytokines inhibitors are your dupilumab, the monoclonal antibodies are there, which can block this interleukin 4 and interleukin 5, which uh, which uh, which are very important for your clonal expansion of your B lymphocyte to your plasma cell. So you can block those interleukins here. Now, IgE, anti-IgE therapy. It is also a monoclonal antibody. Once the IgE is formed, then it has to sit on the mast cell. So if you block this IgE antibody with this omalizumab, then you can prevent this uh, antibody to sit over the mast cell. So this further degranulation of this mast cell is prevented. Then master stabilizers can be used, but nowadays it is not used because of it is side effect like it is very much drowsiness is there. And you have these cytokines inhibitors. After the degranulation of this mast cell, a lot of chemical mediators are secreted and released, like your this your phospholipase and other chemical mediators like leukotrienes, prostaglandins. So those things can be prevented with the help of your cytokines inhibitors, corticosteroids. Okay, and these antihistamines acts on these primary mediators which are released from your mast cell after the degranulations, like your histamines and the proteases. Those things can be taken care of with this antihistamines. Allergen avoidance, this how dust mite, cockroach, bats, pollens, all has shown this option of recommendations. None is recommended. All are options. Means you can use it, but to control these allergens in house or outdoor, it's very difficult. And none of the studies shows that it is strongly recommended or recommended. Now, coming to the role of antihistamines in the management of allergic rhinitis. Antihistamines are used widely in the management of allergic rhinitis. It is useful for treating the itching part, which is because of the release of the histamine. Antihistamines binds to the histamine receptors on the surface of the cells, like your smooth muscle cells. So this binds to these receptors, H1 receptor, and uh, it blocks the further pathway. The role in the treating allergic rhinitis, allergic conjunctivitis in urticaria is there very much. It can control those things. Role of antihistamines in the management of allergic rhinitis. The second generation antihistamines are preferred choice of, of drugs for relieving histamine-mediated symptoms associated with allergic rhinitis. Intranasal antihistamines has a very much advantage because of it is locally acting, and you can give higher concentration of drug to the specific areas, like your azilastine, olopatadine. These are the two intranasal antihistamines which are US FDA approved. Now coming to the decongestants, you have the oral and topical decongestants. The orals have very limited use because and it is not available easily. Regarding your topical, it should not be used more than 3 to 5 days, and should be used with very much cautious. Here I like to add one thing. This topical nasal decongestant should not be given in your pregnant lady because of the preterm labor. So you should be very much cautious about that. Now coming to the ideal parameters. After seeing so much of antihistamines, which is the ideal antihistamines in our practice? We should be so ideal antihistamine should have some uh, criteria, like it should be potent and selective activity on H1 receptor. There should not be no clinical relevant pharmacokinetic interactions with food, medications, or other proteins, intestinal proteins. There should not be interaction with cytochrome P450. It should be having rapid onset of action, longer duration of action, so that you can give once daily dosing. No potential for tolerance development. Then, efficacy wise, it should be both effective in intermittent and persistent allergic rhinitis. Then, it should be effective against all nasal symptoms, and there should not be any side effects like no anticholinergic activities, no weight gain, no sedations, no cardiac safety, and potential use in pregnancy and breastfeeding. Uh, so So these are all your qualities of a best antihistamine. So coming to the different antihistamines which are available are these on the left side, and depending on the non-sedating property, less sedating and sedating property, we have such a huge list of drug. So among that, the top is your bilastine, then you have the olopatadine, fexofenadine. These three have uh, non-sedating properties. So you can choose from either of them. The olopatadine oral tablet is not available, so it is for the to control the eye symptoms. So we have only bilastine and fexofenadine. And regarding the fexofenadine doses or other things are there, decide. And you have the most sedating property is with your diphenhydramine and chlorpheniramine. They are all sedating properties are there with this drug. Now, regarding leukotriene's receptor antagonist, it blocks the cisternyl pathway, and it cisternyl pathway after the uh, arachidonic acid is break down into prostaglandin and leukotriene pathway. So at that pathway, it blocks the leukotriene. Uh, this leukotriene blocks that pathway. So it helps in your aspirin induced respiratory disorders and in your asthma therapy. So we should be very much cautious about the use of the montelukast, because this should not be given for more than 3 to 4 weeks. Otherwise, there will be some neurological symptoms will be there, neuropsychiatric symptoms. Role of intranasal corticosteroids in the management of allergic rhinitis. So it has a very huge role because it acts as a uh, multiple sites, and acts like a acts with every corner of the inflammatory process, and it is the main treatment of mainstay of treatment for allergic rhinitis. It acts by decreasing the influx of the inflammatory cells and inhibiting the release of the cytokines, and this is very much effective than your oral and intranasal antihistamines in the treatment of allergic rhinitis. The maximum effect occurs after the use of 2 to 4 weeks of use. So the patient should not be expecting that I will be relieved after taking the intranasal corticosteroids within 7 days or 5 days. We should explain to the patient that regarding the use, that patient will be benefited on long term basis, and we should continue the treatment as per the advice of the physician. Now these are the different areas where this intranasal corticosteroids acts. It decreases the apoptosis of the eosinophil, it decreases the number of the eosinophil in the submucosa. It decreases the cytokines. It decreases the number of the mast cell. It decreases the cytokines released from the mast cell. Decreases the IgE production. Decreases the number of the dendritic cells. Decreases the number of basophil, and consequently it also decreases the cytokines like ICAM, that is intracellular adhesion molecules, which attracts the neutrophil, eosinophil to the submucosa extravascular system, and it decreases the permeability also. So the tissue edema is less, there is less fibroblast, and there is less chemokines also. Decreases the mucin secretion from the gland cell, whereas it helps in the uh, T regulatory growth factor beta and interleukin 10s are increased. So this is a positive feedback from with the help of your glucocorticoid. So if it is increases, then your type 2 dependent on this inflammatory process is reduced, and the patient will go into uh, beneficial effect of your type 1 type of cell. So this is something important you have to remember these things. Now regarding the different, you have the different intranasal steroids available. You have the fluticasone furoate, promethazine furoate, fluticasone propionate, budesonide. So among them, you have the least bioavailability is your of your mometasone furoate. So and you can use the fluticasone furoate, fluticasone propionate safely. Others have higher your systemic bioavailability of 30 to 50%. So you have to choose it, choose them uh, very selectively. Now, as per the recommendation from this ASCIA, the management of allergic rhinitis in pregnancy is that it should not this antihistamine should not be given uh, in the first trimester of the pregnancy, and no antihistamine is safe in pregnancy because none of them pass the FDA approval, and you should be very much careful to prescribe the antihistamines in the pregnancy. Recommendations of this Australian Society of Clinical Immunology has said that you can give the intranasal corticosteroid spray with a A category, and saline nasal irrigation can be given. And the currently available intranasal antihistamines have a D3 category, so you should be very much careful while prescribing antihistamines in pregnancy. Now, coming to the anti-immunoglobulin E therapy, that is your omalizumab. Omalizumab is your, as I showed you, where it works. It prevents IgE interaction with high affinity IgE receptor on the mast cell and basophil, because the IgE will bind to this mast cell or the basophil. At that point, this omalizumab will, but it's very costly. One vial will cost you around 18 to 20,000, and you have to repeat the dose on a monthly basis for 3 or 4 months. So it is a costly affair, and it can be given in allergic rhinitis, and it has shown that there is some beneficial effect in decreasing the daily nasal symptom score. It provides a new strategy for allergic rhinitis, but there is still a cost issue that needs to be resolved. For example, the benefits of omalizumab for allergic asthma have been calculated to outweigh the cost, but only in severely affected subgroup of patients. You can use it in severely persistent cases, which can proceed to the asthma, or you are not sure if this patient will proceed to the asthma. So in those cases, you can give omalizumab on a trial basis. Now, a little bit about the immunotherapy, how the immunotherapy is helpful, because once the uh, pharmacotherapy fails and it is not controlling, you have to consider for immunotherapy, because this is the ultimate treatment of your allergic rhinitis. Here, the T uh, knife cell, when you give the immunotherapy, there is no progression to when the allergen is exposed. Uh, uh, when its allergen is presented with the help of antigen presenting cell to the T knife cell, this T knife cell will not go to the will not differentiate into T2 helper cell. Rather, it will go to your it differentiate into T1 helper cell or T regulatory one cell, and transforming growth factor beta will be produced, and interferon gamma will be produced from these two cells. And this transforming growth factor beta will have a negative impact on the type type 2 T helper cell, and this interleukin 10 will also have a negative impact on the T2 helper cell. So, and so then more and more type 1 T helper cell will be differentiated, and it will form interferon gamma, and which will produce the IgG from the B cell. So this IgG will protect against the allergic response. This is about the in short about the immunotherapy, how it works. Now let's see what are the recommendations from ICAR regarding the pharmacotherapy. Now, pharmacotherapy, as I said, you have the oral antihistamines, you have these strong recommendations. You can newer generation non-sedating oral antihistamines are strongly recommended for the treatment of allergic rhinitis. Then intranasal antihistamine, it is also having strong recommendations. Oral corticosteroids, longer use of oral corticosteroids uh, uh, is not recommended. You can use it for very short duration, and for short duration of like 5 to 7 days in severe persistent cases. Injectable corticosteroid is also not recommended. Intranasal corticosteroid can give, it is given in strong recommendations for the use of intranasal corticosteroids. Oral decongestants, it is option. You should not use it for more than 3 or 4 days. Topical decongestants also, it is an option. It has to be given for a very short period of time. Leukotriene receptor antagonists are recommended against, should not be used as a monotherapy in the treatment of allergic rhinitis. Promoline, promoline is a your muscle stabilizer. It is disodium chromoglycan. It is an option, may be considered in the treatment of allergic rhinitis, particularly the patient with high triggers who cannot tolerate intranasal corticosteroids. Now, intranasal anticholinergics like your ipratonium bromide, it is an option for your uncontrolled rhinorrhea. Omalizumab, there is no indication has been given from the US FDA. It is not approved. And nasal saline, you should it should be given. It is a strong recommendation is there. Probiotics, then oral antihistamines and decongestants, combination of oral antihistamines and intranasal corticosteroids, then oral antihistamines and leukotrienes, they are all having the options. You can use it, you cannot use, you may use it, may not use it. Then you have this combination of intranasal corticosteroids and the intranasal antihistamines. It is a strong recommendation. It should be given, and it should be the first line of treatment. I think yeah, when the monotherapy fails uh, to control the allergic rhinitis symptom, because it has steroids, it has antihistamines, both in a single device. You can use, you can ask the patient to use it. It will be comfortable for the patient, for the benefit. And once the symptoms are score is deteriorating, you can shift to plain intranasal corticosteroids. Most important is, you can see these three, that is acupuncture, honey, herbal therapies. When the pharmacotherapy fails, you can use all those things. You have the options. Some papers are there, I will show you that they have suggested that these are also an option. Regarding surgery, you can do these micro depredator dissection of the inferior turbinate. Then if there is any um, mm, septal deviation. So all those things you can do uh, with the help of your cold instruments or your microwave rider or your electrosurgery. All will give well, give some improvement, significant improvement in the parameters of your total nasal symptom score. So you can use those surgeries to relieve the obstruction so that your pharmacotherapy, local pharmacotherapy acts better. Now, regarding the immunotherapy, what the ICAR has said that subcutaneous immunotherapy or sublingual immunotherapy, they have strongly recommended. It should be advised to the patient with severely persistent allergic rhinitis. What important is that there is one option, that is your intralymphoid immunotherapy. It is it is an option recommendation level, but the studies are still pending because uh, here the interlymphoid immunotherapy, the immunotherapy is directly injected into the lymphoid system through the lymph node under the uh, guided measure, and the doses of immunotherapy is also less in these cases, but still the treatment, it is a viable option, but more research has to be done on this aspect to come to a conclusion. Now, there is a this is a slide which shows that anti-IgE, that is anti this omalizumab, is uh, mixed with your immunotherapy, and which shows that the uh, group, those who are combined group of immunotherapy along with the anti-IgE, those group has a significant improvement in terms of your symptom. So this is again your interleukin, anti-interleukin molecules, and it can be given. It is an option, and but there is no such clear-cut uh, option recommendation is given regarding the use of this anti-interleukin 4 and interleukin 5. Now, what is the future of the treatment option? You have the, as I said, intralymphoid immunotherapy. Then more and more research has to be done on monoclonal antibodies. Genetic study has to be carried out at different places. Cytokines modulation therapies like anti-leukotriene 4 and 5, like etoposide, and its safety profile has to be studied. Acupuncture has to be is there, and rhinophototherapy. Little bit about rhinophototherapy. It has seen that it has some immunosuppressive effect, and it reduces the antigen presenting capacity of the dendritic cell, and it induces the apoptosis of immune cells and inhibits synthesis of release of pro-inflammatory mediators. Now, these are some studies were done which shows this rhinophototherapy can be given in your persistent allergic rhinitis. Now, in conclusion, what we have gone through this 1 hour lecture is that the current treatment of allergic rhinitis are generally effective and well tolerated in mild to moderate cases. But a significant group of patients with chronic severe upper airway diseases continues to experience bothersome symptoms despite adequate treatment. So these patients need to be addressed very thoroughly. Local corticosteroids remains the mainstay of treatment of allergic rhinitis, and research has focused on the improvement of efficacy, side effects, and possible combination with other known agents. Combination of local corticosteroids and azilastine seems to have major improvement in allergic rhinitis patients than corticosteroids alone. Advances in understanding the pathophysiology of allergic rhinitis resulting in finding treatment modalities that are geared toward being curative in nature rather than palliative in terms of symptom control, which includes new drugs that target IgE and other molecules involved in type 2 helper cell mediated pathway of allergic inflammation and immunotherapy by different modes. Although the heterogeneous nature of non-allergic rhinitis poses a therapeutic challenge, newer agents such as neurogenic pathway modulators like your rhinophototherapy have shown promising results. Thank you. Thank you for your patience.
Thank you, sir, for such an elaborate description of allergic rhinitis, and most of the basics have been now cleared. Uh, Sir, there are some couple of questions which we have got through email. Can we go it one by one?
Okay.
Yeah. Uh, so first question which we have received through email is how to differentiate between allergic situation and from that with viral infection. Like some people say like it's allergic rhinitis, some people say it's a viral etiology or something like that. So how to differentiate between these two?
Allergic rhinitis will have like your similar presentation of your viral infection. In viral infection also you will have the runny nose, stuffy nose. Okay. Now the
Yes.
viral infection may have the fever also. So in certain cases you will find fever also. So by fever and certain tests are there like allergic rhinitis is a IgE mediated mostly, immunoglobulin E mediated, and that is viral infection is it is not an IgE mediated. So if you can do the tests, then you can find out serum specific IgE. If you can do, then you can find the answer. If in viral infection, it will be negative.
So second question which we have received is many of the doctors do prescribe antibiotic on the starting of the symptoms of allergic rhinitis. This is a wrong way of approaching a case. But in which kind of situation we can start with the therapy of antibiotic along with the therapies of allergic rhinitis?
Like you have the secondary infection if it is there, along with this allergic rhinitis. In long-standing cases of allergic rhinitis, it is not controlled with the antihistamines or intranasal corticosteroids. Then there will be secondary infection in the nasal cavity. So in those cases, there will be purulent discharge from the nasal cavity. There will be sinusitis. Then in those cases, you can add the antibiotics like a macrolide is there, doxycycline is there, depending on the culture of the nasal cavity secretion.
The third question which we have received is there any role of vitamin C and zinc in symptom control?
Yes, definitely it has a role because it has an immunomodulation property, immunomodulator property.
Yeah.
It will have. It will have. Now there are combinations today. Also, I got one combination that is coming with the vitamin C and vitamin E, zinc, all those things in a single tablet form. So this will be convenient for the patients.
The next question which we have received is in complication of nasal polyposis where patient is refusing for the surgical option, how should we go upon like go on treating the
Nasal
case?
polyposis, you have to think out like this is a separate topic actually. It is apart from the allergic rhinitis. So nasal polyposis, if it is very limited polyp, first of all you have to think that nasal polyposis is a immunological disorder. Because of the allergical disorder, it is coming with your manifestation as a nasal polyp in the nasal cavity. So if it is a very small polyp, you can continue with the medications like your intranasal corticosteroids, antihistamines. So in those cases, this will regress it. And if it is very large on both sides, the nasal cavity is full of polyp, and on CT scan, if you see that those sinus, all the sinuses are wiped out. Every sinus is blocked, ostium is blocked. In those cases, you have to remove those polyp and you have to advise the patient to take these intranasal corticosteroids on a lifelong basis because this will recur back.
Sir, I think we have done with all the questions, and I would like to thank you for sparing your time and giving us such a good insight on this topic, allergic rhinitis.
Thank you
I
very much.
would, yes, sir.
Thank
Thank
you.
you, sir. And I would request all of the attendees not to log off because we will be giving a short message. Let me share the screen. First of all, I, on the behalf of Walter Bushnell Healthcare Foundation, would like to thank all of our attendees. So Walter Bushnell is an Indian pharmaceutical company, and it has been providing a quality drugs to our healthcare sector, and most of our brands are well known to most of our doctors. And to be more precise, why our brands are preferred is due to its better quality. uh, Walter Bushnell has won number of laurels in the quality, and it has got 3 state-of-art manufacturing plant and 2 in-house research and development centers. And it has also been a winner of prestigious Pharma Excellence Award in 2018 by ASSOCHAM. These are few of our known uh, brands. I think most of the doctors, most of you would be aware of. Today we are trusted for our brand Drotin, that is antispasmodic. So it is one of the most preferred brands amongst all of the physician, pediatrics, and gynecologists and consultant physician. We brought Urispas in India, which is a well-known urinary antispasmodic. Then we also brought a modified release nitrofurantoin, that is Martifer, which is one of the first line treatment for urinary infection. Then we have Uliza. Then we gave Podclor. We brought India's first lactase enzyme supplement, that is Yamu. Then we gave 100% purified diasmin, that is venusmin, for the treatment of hemorrhoid and CVIs. And this we brought Tamsin and Tamsin D, that is tamsulosin and tamsulosin dutasteride for the treatment of BPH. And of course, we cannot forget Amplox. Okay, this is one of the first very old brand of us, and which is still prescribed by most of our doctors. I take this opportunity to announce the launch of a new antihistaminic, that is bilastine. We have launched bilastine by the, and it will be there by the brand name of Bila Life. And we also have a combination of bilastine and leukotriene receptor antagonist, that is Montelukast. So what is so great and what is so differentiating point about bilastine or Bila Life? Bilastine is a new drug in India. It is a new generation antihistaminic in India. So what are the points which are differentiating bilastine from the older generation? Now, if we go back to our history of antihistamine, we all know through our pharma textbooks and all that first antihistaminic to come in the world was during 1940s. Okay. And if you recall, few of our older generation or the first generation antihistaminic like chlorpheniramine, terfenadine, and astimazole, these are termed as a older generation, or you can say it's a first generation antihistaminic. So the drawback of it was that it had to be dosed multiple times in a day. It had cholinergic side effect. It was sedative in nature. It used to cure the allergic symptoms, but it used to give sedation as a side effect. It used to have cholinergic side effect, and of course, for the patient of heart and patient of hypertension and all, some of the older generation antihistaminic was not suitable for them. So in during 1980s came the new generation antihistaminic. Okay, so most of us know these by name like cetirizine, loratadine, desloratadine, levocetirizine, and fexofenadine. So these new generation or the second generation antihistaminic, as we call, okay, one of the greatest advantage of it was that uh, it had lesser dosing frequency. All of these drugs are once day. It had lesser sedative side effect, lesser side effect, I mean to say cholinergic side effect. And when we talk about lesser side effect in terms of sedation, still few of the molecules like cetirizine, levocetirizine, and higher doses of fexofenadine, like 180 mg, it can cause sedation as a side effect. So, is there any place for improvement? So many of this new generation take more than 1 hour to act, and many do not give round the clock symptom control. That means they are not acting for a day. Okay, so their action is finishing within 24 hours or less than that. Okay, so if we all recall that ocular symptoms of allergic rhinitis where the eyes get red. So most of the oral antihistaminic, they are not approved for relieving the ocular symptoms of allergic rhinitis. There we have to depend upon the ocular eye drops of, like, take for instance, there are few ocular eye drops like olopatadine and all, but none of the oral antihistaminic has been approved by the drug regulatory authorities for controlling the ocular symptoms of allergic rhinitis. Now, many of the antihistaminic, even a new generation antihistaminic, they are metabolized by the liver. That means they are being used by cytochrome P440 enzyme for their metabolism. And let's not forget, if there is a patient of cardiac patient, hypertension patient, diabetes patient, they might be taking the drug, and so all of the cardio drug, hypertension drug, and diabetes drug, they are they will be utilizing the liver isoenzyme for their metabolism. So those antihistamine, there are many antihistamine, the new generation antihistamine, which use liver isoenzyme. So there is a chances of their having interaction with these drugs. So most of the new generation antihistamine, they also have to be altered. That dose has to be altered if a patient is suffering from hepatic impairment, renal impairment, and elderly. So, and most few of them, they are not suitable for the cardiovascular patient, where they use a term caution in their prescribing information. Though less sedating, but still they are known to cause sedation as a side effect. So, what's new in antihistamine? In the new generation antihistamine, in second generation antihistamine, there has been a new approval in India, that is bilastine. Bilastine, I would like to share the history of bilastine. Bilastine is not a new drug when we talk about the world. It was first approved in 2010 in the European nations. So it's a well used and well practiced drug in a few of the countries like European countries and African countries. Okay, but in India it came in last year 2019 end. So what are the differentiating points of bilastine when we compare it with the new generation, the other antihistamine? So when we talk about allergic rhinitis, these are the symptoms which comes onto our minds, like sneezing, watery nose, blocked nose, heavily congested nose. itchy nose, and of course red itchy eye. That is ocular symptoms of allergic rhinitis. Okay, and one thing which we often neglect is that allergic rhinitis itself can cause sedation. Okay, it can cause daytime somnolence. Why? Because most of the people who have got blockage of the nose, heavily congested nose, they do not get proper sleep, and the very next day they generally have somnolence. So there are many studies in teenagers which has been shown that when they uh, when they are suffering from allergic rhinitis, they don't have good sleep. They are waking all through the nights, and hence the very next day they suffer from the somnolence. So if we see all the guidelines of allergic rhinitis, like ARIA guidelines, that is allergic rhinitis and its impact of in asthma, they say that when you have to choose an antihistamine, okay, choose the new generation antihistamine, choose the second generation antihistamine, those antihistamine which has got least chances of causing sedation. That is, non-sedating antihistamine should be recommended as a first choice in cases of allergic rhinitis. In fact, when the eyes are involved, then we call it as allergic rhinoconjunctivitis. So, as I as I would also like to repeat this, that non-sedating antihistaminic or the new generation, not all of they are not approved for curing the ocular symptoms of allergic rhinitis or the allergic rhinoconjunctivitis. There we depend upon the topical antihistaminic. So bilastine, which is supposed to be the now the best in class antihistaminic amongst the new generation, how does it differentiate? It is differentiated from the older generation because it is first antihistamine to be studied also in the ocular symptom, not only in the nasal system, but also in the ocular symptom. Hence, the drug regulatory has approved it in allergic rhinoconjunctivitis. And the best part of this drug is that it does not cross blood-brain barrier. Okay, it does not cause sedation. So, Life 20 mg contains bilastine, and what makes it as best in class antihistaminic, it's that it has got best affinity towards H1 receptor. It is not metabolized in the liver. It is excreted unchanged in the urine. Okay, and hence it has got lesser drug interaction. So this makes it as a safest alternative for those patients who are taking the treatment of hypertension or any cardiovascular diseases, the diabetic patient. Okay, and also in patient of uh, like those patients who are taking the treatments of for their urological symptoms, like it could be OAB and all. Okay, BPH. It is supposed to be safe in all types of patient, comorbid patient. It does not interact with alcohol. So people having renal impairment, hepatic impairment, and elderly patient, they do not require dosage adjustment with bilastine. Hence, it can be safely used by all types of the patient. It does not penetrate the brain, so it does not cause sedation. So, and it will not affect the psychomotor and analytical skill of a patient. Like those patients who would like to operate on heavy machinery or who are drivers, pilots, and all, it is safe for them. And there are trials to back this data that they are also safe in the pilots, driver, and those people who are using the heavy machinery. It is non-cardiotoxic. It does not disturb the QTC rhythm. So there is a trial which was done where 10 times the dose of what is recommended, that is 200 milligram, was given to the patient, and it did not change the ECG waves. So it is very safe. 20 mg is extremely safe for the cardiac patient, and it is also safe for the comorbid asthmatic patients. Uh, so H1 antihistaminic in driving. There have been many trials which shows that antihistamine can cause accident. So this is a paper where we are quoting that in an evaluation of an incident of drug use among individual killed in road traffic accident, sedative H1 antihistamine were found to be responsible for 72% of their death compared to 87% of the alcohol, 90% of the cannabinoid, and 97% with the tranquilizer and antidepressant. So here I would like to make a mention that bilastine, the latest generation of antihistamine, does not impair the psychomotor and analytical skill of a person. Hence, it is safe for the driver and even for the pilot. There have been separate studies which have been done on these category of the patient, like pilots and also the those people who required the driving skill, analytical skill. So it is safe for them. What is the dose of bilastine? It's once daily and it has been approved in cases of allergic rhinoconjunctivitis, seasonal and perennial, and also in urticaria, which is most common, one of the most common allergic disorder. So it can be, it is safe for the use in above 6 years and above, and or those people who weigh above 20 kg. It is safe for the adolescents, safe for the adults, and safe for the elderly. This tablet has to be taken an empty stomach 1 hour before or 2 hours after the intake of the food or the fruit juice, because food has been shown to reduce the oral bioavailability of the bilastine by 30%. In pregnancy, there is limited amount of studies. So at present, we would say that take precaution before prescribing bilastine to a pregnant woman. Use only when a woman requires it. Though in the animal study, there was no harm shown. There have been multiple studies of bilastine in allergic rhinitis. It was compared to cetirizine, it was compared to fexofenadine, both low dose and both the high dose, and also desloratadine. So summing up, amongst all these antihistamine older generation, it is bilastine which shows a very good efficacy, not only in the nasal symptoms but also in the ocular symptoms of allergic rhinitis. Hence it is approved for allergic rhinoconjunctivitis. So it has got lesser sedative side effect than the other antihistamine like cetirizine, which was proved in the clinical trial. It was having a better symptom control, the nasal and the ocular symptom control vis-a-vis the fexofenadine. And bilastine has been used in the cases of perennial allergic rhinitis for more than 1 year. So it is highly safe. We also have a combination that is bilastine and Montelukast leucocetrizine for those patients who are recurrent sufferers of allergic rhinitis or who are suffering from perennial allergic rhinitis and patients of allergic rhinitis with asthma. We all know that there are two phases of allergic reaction, that is early phase and late phase. In early phase, there is the role of antihistaminic, but antihistaminic do not have role in the late phase. Late phase, some of the symptoms in the late phase is blocking of the nose, heavily congestion of the nose, where there is an element of inflammation. So hence we add Montelukast for a better symptom control. So the combined treatment of bilastine and Montelukast is effective in recurrent and resistant cases of allergic rhinitis and perennial allergic rhinitis. So with that, we come to the end of this session. I would like to thank all of the attendees of this webinar, and I would also like to pay my thanks from Walter Bushnell team to Dr. Kripamani Nath. Sir, we thank you for coming and giving us lecture. Thank you all. Thank you all for attending.